talk to you today about developing your plan of care and writing physician orders. First of all, we want to understand developing the plan of care. Also, this form is referred to as the 485. The 485 is a standardized form from Medicare that has all the aspects that's required to complete that 485 to be able to bill Medicare. It's also used in private duty. A lot of the payers want to see a 485 in that same format that you would use for Medicare. The form, once it's completed, is very patient-specific based on the assessment that's done on the admission visit and outlines treatments and interventions and goals and so forth for the patient. So the plan of care, or what we also refer to as the POC or the 485, or treatment plan, we use that to develop and have signed physician orders. It communicates care that's being provided or that's been ordered by the physician for the patient. It also lists our visit frequency, how often we're going to see the patient. It also details our treatments, what we're going to be providing to the patient, whether that be teaching, wound care, injections, whatever types of care we're going to be providing. It also describes our goals for the patient so that we know if the patient's progressing, when they're going to be ready for discharge, and then also it demonstrates compliance with all the requirements by the payer. Part of the communication of the plan of care, there's always a copy that's sent to the physician that the physician's going to sign and return back to us. We always want to keep a copy in the chart, and once the physician signs the copy, then we can discard the unsigned copy in the chart. We also want to usually place a copy in the patient's home, although that's optional. But it is beneficial if there's going to be multiple disciplines going to see that patient, or if you've got therapy and nursing or home health aides. It's just very helpful to have in the home. We also recommend that your case manager also has a copy with them so that they can keep track of the patients when their recertification is coming due, and the visit frequency and so forth to the patient is always where they can access it. So as far as compliance, the physician, we also refer to them as the certifying physician for Medicare, signs the plan of care, the 485, and part of that signage states that the patient is meeting the requirements for receiving services at home and for us billing Medicare. Some states will allow for other than physicians to sign the 485 or the plan of care if it's not Medicare, but for Medicare, the physician always has to sign the plan of care. Also, the plan of care recognizes that the patient's homebound and meets those requirements, and a lot of our private insurances also require those patients to be home care to be able to qualify for their home care benefits under their insurance or whatever plan that they may have, that there's an intermittent skilled need, that the patient's under the care of that physician that's signing the plan of care, that they authorize whatever care is on that plan, that the nurse or therapist or home health aide can provide those items. And they also agree that they're going to periodically review the plan. And those, again, are all requirements that Medicare requires, and most of the insurances also are going to require. Again, the plan of care is the primary document that the regulatory and the accrediting bodies use to survey to make sure that you're in compliance not only with the Medicare requirements, but also some state license laws. During the survey, when the surveyor looks at the plan of care, they're going to base most of their report, if you get a plan of correction, based on that plan of care and that whether or not other documentation matches it and supports that you're following the plan of care. Remember, the plan of care is the physician orders, and so if the documentation doesn't show that you're meeting the physician orders, then you're going to be out of compliance. Also, the fiscal intermediary or your payer, if it's not Medicare, is going to use the plan of care to determine if services are have been provided according to that plan and whether or not payment is going to be made in the event that your chart is audited. And again, that could be Medicare or it could be a private insurance. So the process is that the initial plan of care of 485 is created from the information that's collected on the admission visit. For Medicare, that's going to be your start of care OASIS or OASIS C1. After that admission is done, the physician should be called by the clinician that's performed that assessment and review the findings, and also then get a verbal approval for the plan of care. It may not be the physician that you speak to in the office. It may be their nurse or their agent that's in the office. That's okay, but there should be communication, and there also should be documentation, that last bullet point, that the physician was contacted and that approval for the POC has been received. We do see this as a deficiency from time to time, that wasn't completed. So again, the home admission process is about gathering information that's going to be needed to complete the POC, and also to support what care and to what extent the patient needs care, so that if you're billing Medicare, your payment will be correct. So it includes the start of care OASIS, and in that start of care OASIS, the clinician should be looking at the current health status and also the medical history. And you should have documentation of either a discharge summary if it's coming from a hospital, or a history and physical from a hospital or a facility to support the documentation that the clinician puts on the OASIS. The OASIS C1 has locators throughout it, and they're numbered to match the 485 so that you can develop the 485. Now, if you're having a software that's going to be developing your 485, it will create that 485 based on the answers that you put in there on the OASIS. So usually when we see the 485, if there's any nursing involved, then the 485 is going to have nursing and home health aid services. If there's not going to be any nursing, then you may see physical therapy that's using the 485. Regardless, there always has to be a 485 written for the patient. On box 21, that's going to contain orders for the disciplines and the treatments, and that also includes the visit frequency. So usually the nurse will go out and do the admission assessment, and if nursing is going to be in with the patient, even if there's therapy or a social worker or home health aides, the nurse has to be the one completing the OASIS C. That's a Medicare rule. Once the nurse goes out and she'll put on her 485 and her OASIS that the PT or OT or speech or whoever else is going to be in there is going to evaluate and recommend a plan of care for the patient. So once the therapist or the social work completes their initial assessment, not the OASIS, they'll just have their own initial assessment form. It's usually a couple of patients. They're going to develop their own plan of care. Not a 485, but just a plan of care. But on that plan of care is also going to be the visit frequency, their orders, and their goals. Some agencies will incorporate that plan into the 485, but it becomes very long. And sometimes the softwares won't do that. So you'll have the 485 and then also possibly some plan of cares to supplement that 485. Remember, those plans of cares that are assigned or created for the therapist or social workers, those also need to be sent to the physician for signature, same as the 485. So it's possible that you could have a 485 that has nursing and home health aid services on it, and then you could have a plan of care for a physical therapist, OT, a speech, and or social worker, any combination of those. If therapy services only is provided, and we noted that before, then they can do the plan of care on the 485. This is what the plan of care looks like, and you'll know that I've made some notes. The plan of care goes from boxes 1 through 27. And the OASIS forms, if you're using a hard copy from a MedPass, which we give you a sample of, it will have on the OASIS the 485 box numbers next to the questions where, if answered, then that will pull over to your 485, and that's the way this computer software does it as well. So you'll have questions that has a start of care date, certification number, medical record, so forth, and I've given you some locators where these answers are going to be, or where you're going to pull those from on different pages, so you can refer back to this. Same thing with, now we're into boxes 18 through 20, and again, the answers or the OASIS questions, once completed, will pull into the 485 in these specific numbered boxes. Box 21 and 22 are very unique to the patient as well, but these come from, box 21 will come from a number of pages on the OASIS. So anywhere where there's orders, whether it be teaching or assessments or processes, all of those will pull into this box 21. This is where you'll note that we're putting the frequency, what discipline is seeing the patient, what the frequency, and how often or for how long are they being seen. And then 22 also, that's on the last page of your OASIS. It will pull from there. Once you write the goals, every patient should have a rehab potential, and also there should be discharge plans written for the patient. Box 23 is where the nurse will sign a verbal start of care, and that verbal start of care and date should be the admission date. 24 will be the physician's information. Again, that's going to come from page 1 of your OASIS. And then when you send it to the physician and it comes back, he will sign it in box 27 and hopefully date it. If he doesn't date it in box 27 when it comes back to you, then go back to box 25 and date the date that you received the signed POT back. You also should be maintaining some type of either manual log on your plans of cares in your orders, or using your software so that you can track them and make sure you're getting them signed and returned back to you timely. This is a sample of a plan of care. Is the certification period. We're going to talk about that in a little bit, but that has to be 60 days exactly. Medical record numbers there, and when you first start doing these plans of care, especially if it's for your first 10 and you don't have your provider number, that box 5 and box 1 where it's got a patient's claim number, those may be blank. Number 1 actually is the patient's Medicare number. So on the first 10, you can leave box 1 and box 5 empty. That's okay. You won't get penalized for that, for your survey. Again, moving through, and all of the boxes should be marked with something on them. And again, they should be tied back to your 485, or your OASIS, excuse me. Box 21, you can see that box should always start with your frequency, and then onto your assessment, and then into your evaluation and teaching of the patient. 22, make sure that you have goals there along with the rehab potential and the discharge plans. So a well-developed plan of care is going to include the patient's diagnosis, any limitations that the patient has, all of the medications they're on, That includes oxygen, any herbal supplements, vitamins, any wound care supplies that they might use, ointments, inhalers. All of those things should be listed there. And the patient also should be given a prognosis. If you're not sure of the prognosis, again, that's where you should be conferring with a physician on what should be marked there. The plan of care will identify very clear, measurable goals, so you know when the patient is nearing discharge and when they're ready to be discharged, or if they're not ready to discharge, then that will support the recertification and renewing the patient for another 60 days of service. So again, remember your plan of care actually lays out your roadmap for your treatments and services that you're providing to the patient. So let's talk about some of the boxes that's on the 485. So boxes 1, 2, 4, and 5, let's talk about those first. So we said that for the patients being seen for the initial accreditation survey, boxes 1 and 5 is going to be blank. Once you begin billing Medicare, then you're going to have the patient's Medicare number, and you will also have your provider number once you receive it, so you can put that in there. Box 2 always contains the date of the first visit, and that's the admission visit. Now, if you have a nurse that goes out and does an admission visit, but it's not going to be billable, then that will not be the date of the first visit. The first visit is the first billable visit that's made. Box 4 is going to contain the patient's medical record number. If you have a software, that number is going to be assigned by your software. If you do not have a software, then you need to develop some kind of system to assign medical record numbers. We provide you with a log. You can start those numbers however you want them, 001, 100. You can do letters. It doesn't matter. You can do it however. Remember, though, you need to keep track of those so you don't double assign those medical records number to more than one patient. The patient always keeps the same medical records number. So regardless of how many times you have them on service, the medical record number will never change for the patient. And that's going to be the unique, confidential number that you're going to use to identify that patient. Box 3 is the certification period box. Remember, the 485 is always written for a 60-day period of time. And that has to be exactly 60 days, so you need to count, because remember, some days, some months are less than 31 days, some are 28, some are 30, so you need to make sure that you know exactly that 60-day period. And again, it begins with the first day of the cert period is the admission date, but that has to be in a billable visit. So if you're sending out a nurse to do the OASIS, because the patient's only going to get therapy and the therapist won't do the plan of care or the OASIS, you can have the nurse go out and do the OASIS, but the admission date is not going to be the date that the nurse did the non-billable admission visit. It's going to be the first PT visit when they go out and to assess the patient. And front 2 is the last day of the cert period. So again, the dates have to be accurate, so you need to count out the 60 days. Box 6 to 9. Box 6 is the patient's name and the location where services will be provided. Again, reminder, this has to be the patient's place of residence. So it's either their home, their daughter's home. It might be an ALF. It may be a group home, it may be a boarding home, but again, wherever those services are going to be provided. Box 7 is your agency information. It's not your nurse's information, but it's your agency name and address. Box 8, patient's date of birth. And again, make sure that date of birth on that 485 matches what's on the Medicare card and what's in the system once you start billing Medicare. Box 9 is the sex of the patient. Box 10 is the medication box. And we talked about that briefly. Make sure all the medications that the patient's currently taking or may take, if it's a PRN medicine, is included on there. Prescription, over-the-counter, And that might be, like I said, herbals. It might be supplements. It might be vitamins. It could be prescription creams and ointments. It might be Neosporin, something of that nature, oxygen. If you're providing IVs, it should be all of the IV meds and any flushes. If they're getting IV solutions, that should be on there. And again, PRN meds. And include the reason why that PRN med would be given. So if it's a pain med, that's listed. If it's Tylenol for fever, then that should be listed on there as well. As far as dates on the medication profile and then also on the plan of care, again, those dates should be the date that the patient started taking medicine, not the date of the admission. And we see a lot of dates on there that's the admission date, and that's not correct. If the patient's not sure of the exact date but knows it was somewhere around 4 years ago or so, then you can just use January 1 and subtract. Again, that's going to support you teaching and training any new meds or changed meds. So that's really why the dates are important on the medications. This slide talks about that, either new, changed, or long-standing medications. And again, that's going to support teaching and why the nurse is in there with that patient. So again, just make sure also that your medication profile that's in your file and in your patient's home matches with your 485. And anytime there's any med changes, you should have an addendum order to revise that med profile. And we'll talk about that a little bit more later too. So here's kind of some guidelines of when medication is considered a new med and when it's a changed med. So new med is anything that's been added within the last 30 days. And then changed is a med that the patient may have been on for a while, but within the last 60 days, there's been either a dosage change or a frequency or the way the med's administered. Box 11 through 13 are your diagnosis boxes. For your first 10, if you don't have the correct code, diagnosis code on your diagnosis, your accrediting body is not going to penalize you for that, but they do want to see that the diagnosis that you have listed matches why you're in there and what you're providing for the patient. So if you were in there doing wound care, they would expect to see a diagnosis for open wound or post-op infection or something of that nature. Again, it should be based on all of your care and your treatments, and then even certain comorbidities that the patient may have. And that might be if you have a patient that you're providing wound care to, but they also have diabetes. So diabetes would be appropriate to have there as well. You will notice that on your 485, you have a box 12 for procedures. Actually, January 1, when we went to the new ICD-9 OASIS, that box was removed from the OASIS. So you're not required to complete that box 12 anymore. If you want to put a procedure in there, you can, but you won't be required to do that. As far as primary diagnosis, again, the surveyor will want to see that it reflects the main reason why you're in there providing home care. And that it also supports, or you have diagnosis that supports the different disciplines that's in there. So if you've got therapy in there, there should be some type of diagnosis that would support physical therapy or occupational or speech, in addition to your nursing services. Sequencing those diagnoses will reflect the seriousness of each condition. And that's going to be really important as you start submitting your OASIS and being paid by Medicare. But for your survey, again, the sequencing is not going to be counted against you if you don't have that exactly correct. And remember, certain diagnoses will encompass multiple services. So if you have a patient and one of the diagnoses is aftercare of a stroke or a CVA, then that would encompass nursing and possibly home health aides and even maybe some physical therapy. Pertinent diagnosis or secondary diagnosis, Again, you want to list all of your diagnosis, and they should be ranked in the order of their relevance. So again, an example of that might be, we talked about a wound care patient with wound care, but also had a history of diabetes. So you would want to list that diabetes because it is a secondary diagnosis that's going to be a comorbidity that could impact your outcome of your wound care. And lastly, a lot of people are under the assumption that you need a diagnosis for every medication that you have, and that's not true. And be aware, too, that a lot of medications are used off-label, so it may not be for the actual listing on the FDA for that drug, so you need to be aware of that as well. Part of your diagnosis also should be identifying the diagnosis if they're onset or if the diagnosis is an exacerbation. So again, remembering onset is that it's a newly diagnosed diagnosis, and then an exacerbation means it's a diagnosis that the patient has had, but for whatever reason, it's recently been exacerbated. And again, identifying onsets and exacerbations will help justify the care or the amount of care that's needed for those diagnoses. Locator 21 is your orders, and in there, the minimum things that should be required are your disciplines, and that's all the disciplines that's going to see the patient during that 60-day episode, the frequency of those visits, the duration or how long those visits are going to happen, whether it's for the whole 9 weeks or if it's less than the 9 weeks that's on the episode, and then also the duties or treatments that each discipline is going to give the patient. This bottom paragraph here just is an excerpt from the Medicare Manual, Chapter 7, and it tells you exactly why that has to be in there that way. That is Medicare's rule. So again, in that box 21, you want to be very detailed. You want to make sure that it lists everything that's going to be done for the patient, because the doctor has to sign that. Even if you're taking vital signs and you're doing pulse oximetries, those have to be on there as well. Along with, if you're going to be doing wound care, then it should be specifically spelled out as to every step of that wound care. And that's what this slide talks about. So you wouldn't want to write just wound care per protocol or per doctor's orders, because that's not clear. It has to be step by step. And I've given you some examples here of how unique that has to be and how detailed. And those exact things that's documented on that plan of care should be also put on the daily note. When the nurse or the therapist or whoever goes to see the patient and does that, this is also should match on the note from the plan of care. Again, all of your orders, except for your home health aid, should show a skill. And Medicare will only pay for skilled services in the home, and home health aides cannot be in the home unless there's a skill in the home. So again, if that's not documented on the notes and it's not evident through that plan of care, that's where you're going to get probably some money taken back from Medicare if they ever audit your charge. So again, you want to make sure that every visit shows that skill and it's clearly documented there. The length of time on the plan of care, typically orders are written for the full episode. However, we do see some instances where frequencies will be less than the 60 days. So the episode in box 3 will always be the 60 days. However, the doctor may have that he only wants the patient seen for home care for 3 to 4 weeks. We see this a lot with orthopedic surgeries, where the physician will want home care therapy for 2 to 3 weeks post a knee replacement or hip replacement. And then they want them going to outpatient so they can get a little bit more intense therapy. So again, if the doctor's indicated that they only want it for a certain length of time, that's not going to be the entire 60-day period, then you need to make sure that that's on there the way that the doctor has ordered it. Here's some frequency examples. Again, there should be frequencies for each discipline, and it's always stated in either days, weeks, or months. And it always starts out with a number followed by whether it's a day, week, or month, and then for how long. So that 1 day 14, it means one visit a day for 14 days. 2 week 2 is 2 visits per week for 2 weeks, and then 1 month 1 visit for a month for 1 month. Again, on the frequency, you need to use a real calendar to decide the frequency. Realize that in your policies we have in Medicare's policy or Medicare's guidelines on weeks run from Sunday to Saturday. So know that if, for instance, if the caregiver or the nurse goes out and does a start of care on Saturday, then that's the end of your week. So then on the plan of care, you would write the frequency of 1 week 1, and then however many times you're going to go for the next 8 weeks. So again, make sure that you count those days and that you understand your weeks start from Sunday to Saturday, and you don't blend over into those next weeks and make your frequency incorrect. Medicare will allow, and the surveyor will allow, for some PRN visits. We do see these. But again, if you're going to use PRN visits on your frequencies, there needs to be a reason why that PRN visit is going to need to be made. The reason why these might be important is that if you anticipate, or if a patient has a situation where a PRN visit is likely to happen, that you don't want to have to be calling the doctor every time you need to make a visit. If a dressing comes off, or if a Foley catheter starts leaking. So those are some of the situations where you might write a PRN. And typically we see PRN visits, we'll see at most 3 or 4 per episode. But you can write more. The beauty too about the PRN visits is if you do not make them, you don't have to create missed visit notes. So again, they're there if you need them. If you don't need them, then you don't use them. Box 21 talks about the goals. Again, remembering your goals should be achievable based on the patient and what's real for the patient. It also indicates when those goals, once documented, are going to make a decision that home care services can be ended. And again, that's what Medicare wants to see, that the patient's going to get better, or at least get back to independence, or be transitioned to an outpatient setting so that you can discharge them for home care. The goals need to be specific, they need to be objective, and they need to be measurable. So that way you know when you've achieved them. And it should be very clear of when the patient has or has not met those goals. What's measurable? Measurable doesn't necessarily mean quantitatable, but they must be objective and measurable. And again, so you know when that is, and that could be a time frame, it could be 2 weeks, 6 weeks, it could be a wound that goes from a 6-inch depth to a 2-inch depth, or something of that. Or maybe that the pulse oximetry is going to go from 90% to 95%. You know, something of that. Again, very measurable and objectable. Again, it's very critical that as you develop these goals on the plan of care, that you consult with not only the patient and the family, but caregivers and the physician. And that is part of your documentation on your OASIS. And again, the patient's goals may not be the same as what your goals are. So you need to include the patient, particularly when it's pain goals, and independence goals. They need to be involved in that. Again, discussing the goals with the patient or the caregiver is going to include certain things as attitude toward their condition, relationships, and whether or not they've got willing and able caregivers. That's a big one. Being able to discharge the patient, whether or not there's a willing and able caregiver. You also have to consider the patient's cognitive abilities and emotional status, and then again, their expectations. So again, when you set goals with these patients and tell them, at what point in time, you're going to expect to have them discharged, and they're going to be, that home care will be stopped. Again, this is the beginning of your discharge planning with the patient. So there's no surprise when you get toward the end and the patient says, I'm not ready to be discharged, I still want care, whatever. So again, start this in the beginning. I've given you some sample goals here for both medication and diabetes. Again, make sure that it's realistic for the patient. Pain's another one. If the patient's got chronic pain and they've always had pain level at an 8 or 7 or 8, it's not realistic that you're going to go in there in a 60-day cert period and have them to a 0 or to a 1. So again, same thing with the blood sugar. If they're constantly running, in the high hundreds, it's not realistic, more than likely, that you're going to go in there in 60 days and have them at 80. So again, make sure that the goals are realistic for the patient. Box 22 talks about rehab potential. That has to be in there. Again, you want to have descriptors, good, fair, good, and poor. You can use those, but they should be some descriptors along with that, and I give you an example. And again, they need to be realistic for the patient. Daily visits, just one note about daily visits. Medicare does not like to see ongoing daily visits for a patient unless there's a good, clear, documented reason for why that's happening. These are what we call outliers, and I give you the definition there. So if you're going to be doing nursing visits or therapy visits or home health aid visits, whatever that is, you should have an end date of when those daily visits are going to stop. Outliers are red flags for Medicare, and they will result in an automatic ADR or additional documentation request, because they want to see why that patient needs daily visits. And so if you are doing daily visits, you will be paid more by Medicare, but however, you can expect an audit, and you need to have documentation on why that daily visit's occurring. So again, the visit documentation needs to reflect that the POC is being followed. So, in box 21, an order might be that the skilled nurse is going to instruct the patient on signs and symptoms of hyperglycemia. In box 22, where the goals are, it may be that the patient's going to repeat at least 3 signs in 3 weeks. So in the note, to support that, there might be something documented that the patient was instructed on the signs and symptoms of hyperglycemia, and you can list what those are, or you can put that you provided them with a handout or instruction sheet, and then we also want to put that the patient was able to verbalize back the instructions provided. So also on that note, we would put the progress toward the goals, and that progress would be that the patient was able to repeat the signs of hyperglycemia. So again, remember on your plan of care, which is your orders, that all of those interventions and orders have to be carried out. If not, there needs to be documentation of why that's not happening, and possibly a physician interim order to amend that 485. Also, you should be matching the goals in your documentation on all of your visits. Box 22 also is your discharge plan box. Again, you want to include statements there on when you expect for the patient to no longer need home care services. And I've given you some examples of what's going to happen with this patient once you stop home care services. Maybe until the patient family can take care of the dressings, or maybe when all of the goals have been met. the teaching, the patient's able to take their meds and demonstrate understanding of side effects of their medications, or managing their diabetes, or using their inhalers correctly, something of that nature. Once the initial plan of care is established, that plan of care is not revised on the actual form, and there's never a new one written during that 60-day period. If any changes need to happen to that 485 during that 60-day period, the way that's revised, updated, is with a physician's order. And again, that verbal order can either be done by a phone, or it can be a written document that's sent from the doctor to the home care agency. If a verbal order is being taken, then the clinician, whether it's a therapist, a nurse, an OT, PT speech, MSW, is going to sign and date the order, and it's going to be sent to the physician for co-signature. Now, under Medicare guidelines, all of those orders have to be signed within 30 days of them being written. Stamped signatures are not acceptable. Electronic signatures are, but not stamped signatures. Do note that on that 30 days, there are some states that have different timelines for signing orders. I've listed some of those down at the bottom. So during your survey, the surveyor will be referring back to your state requirements if they're more stringent than the 30 days for Medicare. Remember, too, for Medicare, that all of those orders and all of your plans of cares or research have to be signed before you can bill for services, before you can do a final billing for service, not an initial, but a final. Again, you want to keep all of your validation that the orders were sent. Either that's a fax confirmation or an email, however you're going to be sending those orders. We do give you orders or logs to track those orders. You can do that either manually on your log, or you can do it in your software. But again, someone should be looking at those logs or that report to make sure that those are getting back. And if they're not, then whoever the responsible individual needs to be refaxing them, or calling the doctor's office, or hand carrying those, however you need to get those back to them so they can get signed timely. This is a sample order. Again, make sure that it's all filled out completely, that if it's handwritten, that you can read the nurse's signature, and there has to be a title there. LPNs should not be taking orders from physicians. If you are in a situation where an LPN or LVN must take an order, then make sure that an RN co-signs that order. That will happen sometimes when they're in the home after hours or on the weekend, and they have to call and report something to a physician. They may give them an order. So again, just have the nurse co-sign that. So again, just make sure on that order form that it's complete, all of the patient's information with the physician, the date and the time the order was obtained, specifically about the purpose of the order, that you can read it, that the clinician includes their title, and again, if you do have to have an LPN, LVN take a verbal order, that the nurse needs to co-sign that order. As far as order frequencies, again, the orders need to include the frequency, the duration, and the purpose of the visits. And again, the frequency is the number of visits that you're going to be seeing the patient per week, per day, or per month. And again, it should be weeks, and it should carry you out to the end of the 60-day episode, unless the doctor is ordering less than a 60-day frequency, which usually it's the full 60 days. And here's some examples of a correct order for both a nurse and or an MSW. So let's just review the admission steps for the patient. So first, we're going to receive a referral and an order to admit. Now, if you're billing Medicare already, once you receive that referral and that order to admit, the first thing that you're going to do is you're going to go into the Medicare system and confirm Medicare eligibility. If it's an insurance patient, then you're going to contact the insurance and make sure that you're a provider and that you have an authorization to see the patient, and the patient has benefits to cover the home care visits. For Medicare, you need to admit the patient and also that the physician was informed that that happened. Now, if the physician sends you an order to admit a patient on a certain day and it's past that 48 hours, then that's fine. Then you're going to put on your OASIS the actual day the physician ordered the home care to start. You're always going to assign or make sure your software assigns a medical record number. And again, if it's a patient that you saw before, then you're going to give them the medical record number that was assigned to them before that. Never combine old charts with new charts. Once the patient's chart has been discharged, then that one's filed. It never gets combined with a new chart. Always start new. You're going to contact the patient and family and set up admission, and at that time you need to make sure that the patient is able to sign consents and is competent. If not, then you need to make sure that either the power of attorney or the healthcare surrogate is there to sign the consents and be involved in the care plan. The admission pack that we give you a sample. We want to make sure that you're printing those and putting those together off of your thumb drive. There's going to need to be a packet that's taken to the home, and that we list out what forms the patient needs to sign and what paperwork needs to be returned to the office and what stays with the patient to create the home record. All of the paperwork, once it's returned to the office, there should be an audit of that paperwork to make sure it's complete and make sure the patient record number is assigned on all of those forms and the patient record is created. All disciplines ordered must see the patient within 5 days so that the OASIS can be completed. And if you've got therapy that's seeing the patient, then that's going to be completion of that box M2200 on the OASIS. You want to be able to submit and know, or at least estimate how many visits for the 60 days that the patient's going to receive therapy. Once that OASIS is completed, then the 485 is going to be created, either through your software or manually typed from the form that we give you on a thumb drive. And again, utilizing the OASIS and extracting those different box informations from the OASIS over to the 485. Once it's done, it's going to be sent to the physician for signature. And that should be logged on either your software that it was sent to the physician for signature, or it was logged on your manual log. A rescue copy or an unsigned copy should be kept in your chart until the one comes back from the physician for signature. And it is okay to fax it. You can mail it. However, the doctor wants those 485s sent to them for signature. Also, if the therapy is creating their own plan of care or the social worker is doing their own plan of care, not a 485, that also needs to be sent to the physician for signature, and that also should be tracked either in your software or on your log as well. And somebody should be tracking those to make sure you get them back timely. On your thumb drive, we also provide you with a folder that has patient chart sections. And we want you to utilize that to give you some guidance on how to create that chart and so that it's organized. And again, if you want to use something else, that's fine, but you just want to make sure that all your charts are the same and that they're organized, particularly for the survey visits. All of your patient charts have to be secured. That's either in a locked file or a locked room, and it should only be accessed by approved agency personnel. And you have policies that identify who can go into patient charts. The charts should be audited. We talked about this after the admission and on discharge to just make sure all the contents are present there, and if there's items that's not complete or missing, that's corrected as soon as possible. This is some of the basic chart requirements that the sections will note that you have. When we do an audit for you and when you're looking at your charts once they've been submitted, and at the time of discharge, you want to make sure that the intake form is there and it's complete, that you have an order for home care, that the OASIS start of care was done, all of the consents from the admission packets are signed in the chart and completed, that you have a 485, and also any interim orders that you may have are there as well and signed within that 30-day or less window if your state has a more stringent time frame. There's clinical notes and progress notes in there to support the 485, including any missing notes. So if you're not able to follow your frequency, that you have a missed visit note in there as well. Your therapy notes and your home health aid plan of care should be in there. Remember, the home health aid plan of care is the only one the physician does not have to sign. The doctor has to sign, physician has to sign all of the other plan of cares, including the 485. For Medicare, you need to have a face-to-face, a completed face-to-face in your chart. You have a policy on that. The next form, that NOMNC form, you will have once you've discharged the patient. And again, remember that form has to be given to the patient no less than 2 days prior to the last visit. Any other applicable OASIS sets, so if you have a transfer or if you have a recert or resumption of care, all of those should be in there, as well as your discharge OASIS. If you're going to recert the patient after a 60-day episode, then there also needs to be a 60-day summary that's completed. It has input from all the disciplines that's seeing the patients, and also it should be faxed or sent to the physician for his review. He doesn't have to sign it, but a copy has to be sent to the physician, and you need to have some confirmation that that was sent to the physician. So as follow-up, I want to thank you for reviewing this instructional video. I hope that you found it was helpful. If you have any questions about the 485, we want you to feel comfortable to call the clinical department. And again, you need to make sure that your charts are complete and correct, not only for the survey, but also as you move forward and you bill Medicare or your payer, if you have another payer, so that if you do have a request for documentation or they do a review for your chart, that you're not penalized and money taken away. So thanks again for listening, and let us know if you have any questions and we can answer those for you.